But because it's an ongoing investigation, we don't know much more about what is happening. All we know is that the police did talk to her, and it is an ongoing investigation.
I see that Dr. Misra has her hand up.
Hi, good morning. Thank you, Viraj. My question is, was there any family planning recommendations that were, or the patient was counseled on before discharge?
Yeah, so the patient was extensively counseled postpartum about all options of contraception, and she was offered if she wanted to get any of those methods like an Nexplanon or Depo immediately before she left the hospital, that was also an option, but she did not desire any of those options.
I see that Dr. Dunn has her hand up.
Hi, Viraj. Great presentation. Just about the Hep C thing, I know I've had the same response from infectious disease before. And what they told me before is that since it's such a long course, like minimum of 12 weeks for the treatment, if the patient is non-compliant at any point in those 12 weeks, they then have to like restart the treatment when they're more compliant. So that was the reason they gave me before. I don't know if it's the same in this case. And then my question for you was, this is a very complex patient, obviously. When she first presented to Chandler, it sounds like they understood that in their goal of transferring her to the high-risk OB clinic. From seeing like how many appointments she had scheduled at Chandler or at high-risk OB, do you think that there's anything more we could have done to reach out to this patient and try to support her in the pregnancy, or do you feel like we did everything we could?
I think that we did a lot to try to support this patient. We did reschedule her appointment multiple times, but I think there's just a barrier to care because the patient did not have access to a telephone. So she probably did not even know that we were rescheduling these appointments for her. The patient did mention in her initial OB appointment that she is available by mail. So I think the only other thing we could have done was maybe send her a letter to her home. But I think we tried our best to support this patient.
I see that Dr. Bayat has her hand up with 2 minutes left.
Good morning. I just wanted to make a comment in response to one of the previous comments. I would really urge everybody to be very cautious about criminalizing women who are pregnant, who have substance use issues. I think it's a very complicated area. And when somebody has a complication like an extramural delivery related to their substance use, criminalizing that behavior is a really slippery slope, especially in this political climate that we're in, because we're already criminalizing women for things like miscarriages. So I would really urge us to be cautious about that approach to situations like this. So just, I would really urge you guys to keep that in the back of your head, because the political climate is just going to get worse, and more women are going to be criminalized for things like pregnancy loss that's out of their hands. And if somebody didn't have access to a telephone, I don't know what else we expect of them. And maybe if she didn't have access, like if the hospital didn't have Narcan on, on formulary or whatever, or in stock, like maybe we shouldn't have sent her home until we had it. Just because she's delivered doesn't mean that, like what's going on now with her substance use care, like that is a huge part of her prenatal management. Did we know that she didn't have a phone when she was pregnant, when we kept leaving her messages or kept trying to call? Like, that's a big deal. So, having the police involved when she didn't even have a phone and has a medical condition, to me is a big problem.
All right, well, we're out of time. So Viraj, thank you very much for 2 very interesting cases. Excellent job. And now it's time for us to transition into grand rounds. So in just a moment, I'm going to ask Dr. Bachman to introduce our grand round speaker. But before that, Just a word or two about attendance. We'll be taking attendance using the participants list in the WebEx at 8:10. If your name is listed clearly, you'll get full credit for attendance. The attendance code for CME will be distributed by the email system later on. And with that, Dr. Bachman, are you ready to introduce our speaker?
I certainly am ready, and I'm very honored to be doing this because in 1993, Dr. Ayers was a new attending here, having just completed her residency, and I was a new mom. So we've had a long journey together, and Dr. Ayers is an amazing, amazing individual, not only professionally, but personally, globally, etc. So I'm just going to go through a few of the highlights of her bio. As we all know, she's the Assistant Dean of Student and Multicultural Affairs, the Vice Chair of the Clinical Services for our department. She's also an adjunct faculty at the School of Public Health, and she did her undergraduate work at the University of Maryland in the honors program, and then went to Temple University Medical School for her graduate programs in medicine and OB-GYN training there. And she got her master's in public health here at Rutgers. And after completing her residency, she came here. And the last point that I do want to emphasize, I could go on for many minutes, hours, etc., is that she's gotten many awards. In 2021, she received the Chancellor's Excellence in Diversity, Equity, and Inclusion Award. And as we all know, that she's very involved globally, that she and her husband, Dr. Akins, were the founding members of the nonprofit organization, International Healthcare Volunteers. And I'm just going to leave you with one statistic. This organization has provided over 14,000 underserved women and their families in Africa and the Caribbean. So with that, I'm going to turn it over to Charletta, and I'm really looking forward to hearing this talk on common bleeding disorders in women. Charletta.
Thank you, Gloria, so much for that introduction, especially the times that we've been together now since 1993. Bringing that up makes me even more honored today to speak. And it's truly inspiring, not only for me to be able to share this very important topic, which I'm very passionate about, but it's inspiring working alongside such dedicated colleagues. And I'm grateful for the opportunity to speak to all of you today. The main objectives is, number one, we're not going to really learn about bleeding disorders. It's really how do we navigate with our colleagues as a multidisciplinary team for this very complex problem as OB-GYNs. So I want to actually, we're going to describe the types of bleeding disorders. We're also going to look at criteria that's very common, develop an evidence-based management plan, which will include how do we engage with our hematologists, our anesthesiologists, maternal fetal medicine, genetics, our blood bank, our hospital institution regarding these patients. And also look at how we integrate that in a form where we know the patient is the center and we get the best outcomes we can for our patients. So I have no financial disclosures, but I want to say that I'm going to disclose I'm not an expert. A lot of the information is going to be overall, how do we integrate? It's also noting is that I really want to share with you how we can be an advocate for our patients. I think it was well put by what Dr. Baya had said regarding her comments regarding that last patient. How do we advocate? How do we navigate for our patients, especially when they have other issues that are impacting their health? Before we start, all of you know this from medical school, that before you talk about any bleeding disorder, you have to talk about the coagulation cascade. And I was always very interested in this part. I like complexity. But you have the intrinsic, the extrinsic, and the common pathway. And this is so complex, but it relies on a lot of how we stop our bleeding, how we actually survive after trauma, or little things just as having our menstrual cycle. And for the intrinsic pathway, we see that if hemophilia A, B, factor 11 deficiency, with extrinsic pathway is factor 7 deficiency. Von Willebrand's has more of extrinsic, and some of the common pathway is involved with that as well. And we know that this is important, all the pathway and all the intricacies, the factors, the actual different proteins are all important for a clot to form. Not only the forming of the clot, but maintaining the clot. And the reason why I say that is because sometimes we have delayed bleeding, such as in postpartum hemorrhage, that's 3 to 5 days out. It's because of that part of not maintaining that clot. It's also involved also when we have surgical procedures where we see things are really dry, and then we go back and we don't know reason why the clotting did not occur. We have large volumes of blood in the belt. There's also inherited and acquired reasons for bleeding disorders. And I think the reason why I bring this up is because sometimes we always have to be observant and aware of also asking our patients about medication and herbal products, and also their health conditions such as liver disease, which can also cause bleeding disorders as well. When I was a very young attending, I had a patient that I took back for a laparoscopy, very simple case, a cystectomy, went along no more than an hour and 15 minutes. And I was called back before her discharge that she became hypotensive. And we took her back. Again, we took out of the clots. We didn't see any bleeding. We admitted her the next day, and her family members brought in her medication, and she had these large bottles that had nothing on them to find out that she was on these herbal products she was getting over the mail, and to find out that some of those herbal products also cause bleeding. So it's so important for history taking to actually ask. So the prevalence in women, people don't realize is 1 in 1,000 women have a bleeding disorder, really. And when we look at really heavy menstrual bleeding, and that's defined by having heavy clots, changing pads every 1 to 2 hours, there is often 20 to 30% of those women who have that bleeding or have bleeding disorders. The most common we know is von Willebrand's. We also know that platelet function disorders, where you have a normal platelet count, but the platelets don't function really well. And there's different reasons for that. We have factor deficiencies as well, and hemophilia A and B carriers in women. I want to share with you one of my patients that really inspired me to learn more about bleeding disorder, her and her family. AC, when I met her, was 15 years old. She presented with heavy bleeding. She was seen in the ER the week before and was referred to me because she had severe anemia and fatigue. Her anemia was significant enough that they wanted to give her a blood transfusion. But because her mother's history of blood transfusion in the past and reaction, they declined and wanted to do other management. So she was on PR iron. She also reported that she had heavy menses that lasting for 7 days. She was changing her pad every hour during her first day. And when we asked her, did she have flooding, which I'll talk to you about that word a little bit later, she said she did. She had a history of bruising a lot, and occasionally she had nosebleeds, but that wasn't her main issue. Her past medical history was anemia. She had a surgical history and significant for a tooth extraction where she had bleeding after the procedure a couple of days later, where she had to come back to her dentist to get reassessed. She was in the 10th grade. She played soccer, but her mother was very concerned because she lost approximately a week of school every month. And her family history was for fibroids and anemia. We're going to come back to AC because her story will hit every single component of an individual through reproductive care. So why is this important? Well, women with bleeding disorders frequently experience heavy menstrual bleeding. They also have anemia, fatigue, and they have a diminished quality of life. And I think we don't put that at importance, that quality of life. It really is important to the point where we really need to support these individuals, and mental health is also one of the areas that's usually missed with them. With pregnancy, they have the raising the risk of complications, including miscarriage, bleeding during delivery, and postpartum hemorrhage. For gynecological procedures, these women with bleeding disorders face a higher risk for during common procedures, even like DNCs and biopsies. And the surgeries demand we have specialized planning. And when we talk about specialized planning, we really have to include our hematologists. I know we know a lot, but for these patients, you need to be very, very careful. And the reason why I say very careful is just because someone has a von Willebrand's disease, there's 4 types, and you have another patient is von Willebrand's disease 1, does not mean that they will respond the same. And so their patient plans need to be clearly delineated based on what that patient and how they responded in the past and what their factors are and what their needs are regarding to support them for any surgical procedure. OB-GYN team approach, which we always talk about teams on labor and delivery, definitely needs to come here. And the team approach is to include all of the team members, including nursing, our blood bank, and the planning needs to be perioperative planning and postoperative planning, and in pregnancy, preconceptual planning as well. We know that when we plan and have a team approach in the literature, that the outcomes of these women are extremely significantly different than when planning does not occur. So the key bleeding disorders we talked about, the number 1 is von Willebrand's disease, and it affects about 1 out of 100 women, but is often undiagnosed. And impact is usually when they present as heavy bleeding or they present after postpartum hemorrhage. The impact of pregnancy, as we talked about before, or the risk of miscarriages. There are 4 types of von Willebrand's. Type 1 is typically the most common and very mild. It includes like the bruising, nosebleeds, extended bleeding after surgery. The type 2 is like a qualitative deficiency of von Willebrand's. And that one has 4 different types underneath it. And this one has, is more with the protein is not properly working regarding, and they have 4 different subtypes. And their risk and outcomes are different as well, because type 2N von Willebrand's have significant risk factors for our outcomes. The treatment usually is DDAVP, von Willebrand concentrates. Now the concentrates come where they are recombinant, which has been a really big deal in the research, because some of these women, when they would get repeated treatment, would have blood-like reactions and preventing them to use that treatment again. So the recombinant factors have been made a really big impact on this area of bleeding disorders. Type 3 has severe quantitative deficiencies of the von Willebrand protein, and usually we use a lot of concentrates in this, and then the acquired von Willebrand syndrome, which this usually occurs later in life, and it's usually secondary to autoimmune disorders, certain cancers, and and other diseases, chronic diseases that can do that as well. So the other, which I found very fascinating, is the platelet function disorders. And there's a lot of different platelet dysfunction orders, and we're not going to get into all of them, but we didn't really understand them until the last 15 years. When Dr. Bachman, myself, worked with Dr. Claire Phillips, who was head of the division of hematology at that time, and also head of our hemophilia center here at Rutgers, we really didn't know as much. They were still in the lab trying to figure out how can they do assays. We knew that they weren't functioning, but we were trying to figure out the reasons why. And these require specialized platelet function tests that you not always can get in the lab. And that's why it's important that you have the hematologist, because it's at large centers, they actually have their own labs, or they collaborate with our outside labs to make sure that these assays are done correctly and efficiently. These women sometimes are asymptomatic in an OB-GYN setting, but they are very, very concerning because they have this delayed bleeding. The non-hormonal treatments, you see a lot of times they're being placed on tranexamic acid, Amicar, and they're complex cases where you definitely need a hematologist to be a part of this discussion and treatment for these patients. Hemophilia carriers are not as common, but we need to talk about them, the hemophilia A and B, because they have a higher risk of bleeding during childbirth and especially postpartum hemorrhage. And you have special considerations for their baby, especially if the child is male. These are X-linked associated disorders, and you have to, along with any of these, talk with our neonatologists, need to be part of that team, our pediatricians, and our NICU teams. So how do we screen for these patients? And whenever you talk about screening, we need to go back to the basics. The best practice is a targeted history, speaking to the patient and listening. I think that's where I found the most of my learning and understanding when my patient is the active listening when these patients come in, especially after they've seen multiple providers. You also have to be aware that when we talk about heavy bleeding and you say, do you bleed heavily? These bleeding disorder patients might tell you no. And you might say, why? It's because from their families, you kind of determine what your bleeding pattern is based by the individuals who surround you, your mother, your sister, your aunt. So if these individuals have other women who are also bleeding heavily, they see this as normal to them. So you can't say, are you having normal bleeding? That's the reason why it's important for you to say how long, the frequency on your heaviest day, how often are you changing your pads, the volume of bleeding. And we found in the literature that we were trying to find words to describe it, and talking to patients, flooding, it's like a light bulb goes off. That's exactly, Dr. Ayers, what I do. It's flooding. And it impacts their daily life. And that's why, you need to ask teens, does it stop you from going to practice to soccer? Does it stop you from going to games when you have your periods? And one of the things that helped is Better You Know, which is an organization that the CDC and the National Hemophilia Organization, now they call them the National Bleeding Disorder Organization, put together through researchers and academics. And Gloria and I are part of some of the products that they've done, have started this calendar where you can give this to your patient, and over the days that they bleed and is scored, they look at it from a pictorial perspective of what their pads or tampons look like. And based on that score, you can say they are having moderate to heavy or light bleeding. It's very, very helpful and a simple tool that even is online. Teens can actually download this, put it on their phones. And I just highly recommend that you go to Better You Now for that information. Family history is important. Relatives with bleeding disorders usually have frequent nosebleeds. They might not have a bleeding disorder, but they have bleeding after surgery. They also ask about bruising and bleeding patterns. I just had a patient the other day, as I was examining her, you saw all on her thighs, these bruises. It might not be a bleeding disorder. You also need to say if they're safe, because domestic violence can occur there too. But being aware when you're examining patient is so important. So why is this history important? This are the numbers. So as a researcher, the data. What is the data? How do we know? Why is this important? Well, 20 to 30% of teens who need a blood transfusion because of heavy bleeding have a bleeding disorder. 5 to 20% of persons with severe postpartum hemorrhage have a bleeding disorder. 5 to 10% of persons with heavy vaginal bleeding secondary to fibroids may also have a disorder. That is very huge. We didn't believe it, but I'm going to go back to the paper that we did with Claire. And we found out that we didn't exclude women who had fibroids, but we had a high association of them to have a platelet dysfunction. And it was statistically significant with the group that we had when they had their testing. And this is still evaluated, is that from the excessive growth, the autoimmune issues that are going on, but it's something we still need to look at. What screening tools do we have as well? And this is one structured tool that I'd like to put out there. It's talking about the terminology which you would ask a patient. You know, I just talked about self-judgment. You really shouldn't say, you know, they might say no to, do I have excessive menstrual flow, because from their judgment is normal. But you need to ask about how long does it last? Is it more than 7 days? The total numbers of days in a single menstrual period. Do they have 5 days, 7 days? On their heaviest days, how often they're changing the pads, counting the number of pads that they're using during a period of time. Sometimes they'll say that I go through at least 3 boxes of pads through my menstrual period. And number of sanitary pads change per day. These are really concrete questions, and real quick, only 3 questions you really need to ask your patients for you to get an idea of, is this heavier bleeding than you would expect for a normal person to have? And it's something that should be done for annually for all of our patients. And then I really like the self-BAT test. It's a bleeding assessment tools, and it actually goes through 14 categories. And this is for someone more that you're suspecting has a bleeding disorder. This is not should be done for anyone who just comes in for, you know, irregular bleeding, but this is someone you suspect. And it goes through about nosebleeds. It goes through about GI bleeds. It goes through about if they had CNS bleeding in the past, menstrual history. It goes through also other about bruising and the amount of bruising that you have during certain procedures. It talks about dental work. Did you have problems with dental work after bruising? It's a very good assessment, and you can just go self-BAT BAT, and you can get that assessment. And it's very good for those individuals who you suspect have a bleeding disorder. Now, this is where hematology really should come in. I do not recommend that you, my colleagues, do extensive testing. And I'm going to tell you why, because sometimes we can get tests that are not correct because they didn't go to the correct lab. So I think a CBC, a PT-PTT is fine. You can get the von Willebrand's factor levels, but you have to understand the fact that we're going away from that and actually looking at the activity levels along with the factor levels. The activity level is probably just as important, because we find out that there are some have borderline levels, but their activity level for von Willebrand is very, very low, which it makes it even more concerning. And those are done in Pacific labs, and the assays have to be done a specific way to get the correct answer that you need to be able to take care of the patient. You may need, after you do baseline labs, go into other things like the fibrinogen level, the platelet function analysis with aggregation testing. But hematology needs to be part of that discussion and assist us when we get to that point. I just want to go over some things that are commonly used. We as OB-GYNs, we've started using transemic TXA much more, and we feel more comfortable with it, especially on labor delivery, for postpartum hemorrhage, for other bleeding. Some people have also used it with patients with menstrual problems as well, after they've diagnosed for 5 days of their menstrual period to maintain so they don't get severely anemic. And NSAIDs are underused because it also helps with the fibrinolytic process. And it can also be used for pain because those non-steroidals have been known to decrease blood loss. So in our patient population, especially in fibroids, we've used and other bleeding as OB-GYNs. These two we use very frequently. But there's other medications too that you should be aware of. We're not going to get too deep into it, but you need to be aware of and what their possible complications are. In von Willebrand's disease, we use DDAVP very often. However, we have to be careful of this natural hormone. It's vasopressin. It's an antidiuretic and it's pro-hemostatic as well. They also use DDAVP in bedwetting, as well as other things. It truly is used a lot with hemophilia A and von Willebrand's disease. And we know that it works very well. You have to be careful with the DAVP because not all von Willebrand patients will respond to it. And so the hematologist will do a response test to it to see if they do respond, because there's certain groups that don't respond. And you need to know that, because then you should use other products. It will stimulate the von Willebrand factor, and it causes hemostasis. But the risks are that it can be hyponatremic, and causing water retention. You can get mild hypotension, flushing, and headaches. Water intoxication is a serious side effect of this. So you have to be very careful with the type of fluids that you give patients who are on DDAVP. The other is Hemopate-P, which is a plasma-derived concentrate of von Willebrands and factor VIII. It's used primarily to manage von Willebrands and hemophilia A. And then you have factor VIII, other factors that you can give alone. What has happened with these factors? They are mainly used, they're blood products, so you need to be aware of that. But now we're getting more and more recombinant factors where you don't have to worry about the side effect of blood reaction. Then you also know that we also treat bleeding disorders when they're having excessive bleeding, also to replete them by cryo as well as FFP. When we have women with bleeding disorders and they have heavy bleeding, oral contraceptives is still a form that we use. And it helps regulate the menstrual cycle, and it's 80% effective in these women with bleeding disorders. It's ideal as an adjunctive treatment. And in many of our teens with bleeding disorders, we've used this as continuous OCP to help them because of the amount of bleeding they're doing, and also to try to help them maintain their hemoglobin. The other, over the last 10 years, is the progesterone IUD, which has been very, very helpful. We've seen 70 to 90% effectiveness when we use this approach. It's long-term. A lot of my patients have been doing very well on this. I have some of my perimenopausal patients who have bleeding disorders that we've used this for, who didn't want an ablation. It's highly effective. We get it when we place it, and the patients have altering in their lifestyles because of that. As I talked before, there's other surgical options such as endometrial ablation. The success rate is 50 to 70%. We have a higher failure rate in bleeding disorder patients at sometimes because it's not, you do ablate, but even if there's a small area that's missed, you can have a large amount of bleeding just from a small area if we're not cautious. But when we talk about treatment, and I always say that it's great, but in women, sometimes we forget that these are reproductive individuals. And as soon as they get into that area, preconception counseling is really important. I can't tell you, when I've gone to some of the conferences, the concerns that patient advocate groups have, that women are not given the information preconceptually before they get pregnant, that they get a lot of counseling on that first prenatal appointment and referral to MFM. But if these women knew prior, they probably would be, it's not that they wouldn't go and do family building, but they would have a lot more resources and understanding, and as well as their partners, how they're proceeding into pregnancy, which has a lot of potential complications. So this is very crucial, and also to involve the hematologist when women are even thinking about pregnancy, because there are certain things that they will do and provide them resources regarding maybe even changing certain medications at that time. The other is for certain genetic consideration for these. Now, usually we don't do genetics for von Willebrand's patients, but we do, when someone has von Willebrand's, we do counsel them about the potential that their other members of their family might have it. And I'll share with you a case regarding that, as well as their offspring regarding risk factors. But there's the hemophilia with the X-linked, which can have a significance on the male gender child. We really need to make sure that we do genetics regarding that. And sometimes there are certain things that they would do for a determination before even embryo transfer for this group of individuals. Menstrual management in antepartum management, we're not going to go too much, but during pregnancies for these bleeding disorders, I'm going to take, for example, von Willebrand's. We check their levels. We want them to be above 30%. They check the activity of the von Willebrand's to help guide them how they're going to be able to dose them, especially when they go into labor and especially postpartum, because those von Willebrand levels usually tend to go up during the third trimester, but they can drastically drop after delivery. And that's the part where usually people get concerned on labor and delivery about these bleeding disorder patients, but you really need to be concerned after they deliver. That's where the time that we need to be very, very observant, cautious, and give our patients and their partners clear directions and when to call and when to come straight back to the hospital. Now, delivery coordination is something that we really need to be, and postpartum hemorrhage, we talked about, even the balloon and other things that we do for controlling hemorrhage are all used during for bleeding disorder patients, along with tranexamic acid and oxytocin. But one of the things is that we don't talk about is availability of blood products and hemostatic agents. We are so lucky here at Robert Wood Johnson Barnabas. We're a trauma center, so we have blood products available. But you don't realize in some other hospitals, blood products are not always available in the hospital. That's the reason why there is a major push that women with bleeding disorders really should be delivered and managed at a hemophilia center. There's about 150 of them around the country, and Robert Wood Johnson is the regional hemophilia center for New Jersey, and we have another center that's up North Jersey, as well as Princeton now. We just need to be aware of that, and because we are so, and this is for the residents, because you're so used to having these products, you have to be careful that when you go to another institution, it might not be the same. So it is, it would be not in a good way for me not to say this again. These women need to be at a center that has a 24-hour availability of a hematologist that works with bleeding disorder patients, because not all hematologists work with all bleeding disorder patients. But a bleeding disorder patients, also that your blood bank feels confident to be able to provide for those factors, provide for those others, and that your pharmacy has the medications that your patient needs. And the other part of this too is that nursing, and sometimes we do not pay enough attention to how we train our nursing. The nursing staff need to also be aware, because in a lot of times, like tranexamic acid and Amicar, they have a half-life of 2 hours. You can give it also IV. There's a way that you give it IV. Humate P, you have to have a certain refrigeration for that, or it's not as effective. So we need to have teams that are aware of not only the medication and the dosage, but how to give it, what are the side effects to look for, because it can happen very quickly, such as when DDAVP is given post-surgically, if the person starts having water intoxication, or we start ordering IV fluid, and how even our anesthesia, how we are taking care of that patient holistically. For GYN, as we are surgeons, the preoperative planning is so important. Again, similar to what I stated before, as well as our postoperative care. And the pre-procedure blood work, we need to assess the hemoglobin levels, the platelet count, the coagulation status, and for certain patients, you're going to need to know their factor status as well. We look at their levels. We need to make sure that anesthesia and hematology consult. I didn't get into this for postpartum, but we know that in certain bleeding disorders that you can have CNS bleeds as well. So a lot of cases, most anesthesia will not give our pregnant patients epidurals. There are some that are mild. If you talk to the hematologists, to say that really they probably could, but they understand the reason why they don't, because most of our postpartum, if you just think about it, most of our postpartum, I just told you, most of severe postpartum hemorrhage patients have bleeding disorders, and the majority of them had epidurals. However, we have seen, and it's in the literature, those cases where there's severe bleeding disorders where they have had major clots causing individuals to be paralyzed because of a undiagnosed bleeding disorder, a patient who was in labor. We have to be cautious about that. So anesthesia is very, very important, especially when we are doing surgical procedures on them and the hematology consult as well. For postoperative care, I think this is where patient and family education is key. And I will share with you where some other patient education is for us to use and guide our patients with bleeding disorders. Because one of the things they feel as though is that this group, when I've talked to patient advocates, they feel as though they're teaching us. That when they come in the room, that they're teaching us because a lot of times the bleeding disorders is so complex that they might be the only one we've seen before. That's the reason why teams are important. And I have been an advocate that when certain individuals see more, it doesn't mean that I know more, but I know some of the warning signs. I know when to ask the question of how long does this drug last? And then I can share with my hematologist that the placenta doesn't just come out after the delivery. It could take a minute or it can take up to 45 minutes. So when they're giving the dosing, we need to be able to discuss that kind of when we're dosing individuals. We need to do this in a team approach. And that delayed bleeding can be very traumatic. It can also be the reason, or the patient might delay, and they can't delay coming in because they could get into crisis mode before they reach the hospital. So those kind of information and the way that we share that information with our patients and their understanding is so, so important. So you heard me talk about this multiple times, collaboration. And we are a hemophilia treatment center. I think we're going to be changing our name to a bleeding disorders treatment center. And I had the privilege of being mentored by Dr. Saidi, who actually established the center. She was internationally and nationally known hematologist here at UMDNJ at that time, Robert Wood Johnson Medical School. And she was a strong advocate for individuals with hemophilia and bleeding disorders. And her main purpose was team. And one of the things she always told me that, medicine is not solo. It's not a solo job. And you also need to not think about who you are, but making sure your patient is centered. And from that, her goal for the hematology treatment center was to make them centered. And so this is just a little thing about what a hemophilia treatment center is. And what they recommend is that you get at least one consultation with the center, and you have your major procedures delivery in a center near you. For some people, that means traveling far away. Individuals who live in New Jersey, they're very lucky. They have 3 different centers they can go to be able to have a safe delivery, a safe surgery regarding this. And what that multidisciplinary team is OB-GYN, MFM, anesthesia, primary care providers, neonatologists, genetics, physical therapists, because some bleeding disorders cause individuals to have bleeding in their joints. And so physical therapy becomes really important. And the one thing we can't forget about is mental health. It also includes the blood bank and lab services. So I had the opportunity to be part of patient education for teens. And there are many advocates, women's and girls with blood disorders. I would recommend that strongly if you want to have more information. That foundation gives great information, not only for patients, but also for providers. The National Bleeding Disorder Foundation is a true advocate. They also support a lot of research in hemophilia and von Willebrand's disease. Over the last 15 years, they've incorporated more information on women with bleeding disorders, which was really driven by women patient advocates, as well as mothers of children with bleeding disorders. And they've made a big push to try to make sure that education is available, as well as giving bleeding disorder individuals support in different mechanisms. They talk about lifestyle as well as planning. Those are the two things that they really talk about. And as an adolescent gynecologist that I also see adolescents, I was asked to do this short video. It's on YouTube. And I'm just going to do a couple of minutes while you do it. So we're actually teaching, you probably can't hear, we're actually teaching the teens about, how to talk about their periods, because we know that most time they don't really know, they don't feel comfortable about it. They don't know what's normal, not normal. And it's just a 45-second video talking about it and actually giving the teens the tools to actually say, this is what is normal or not normal. And we got 1.8 million hits on that. We were very proud, and it was done also with one of our medical students. So we talk about multidisciplinary teams, and this is again physician education. They found that the most important thing was when physicians were not knowledgeable, and they had individuals with bleeding disorders, and they were either their surgeon or their obstetrician or their primary care provider. And CDC has done multiple modules. If you go to the CDC website and put in bleeding disorders, they done modules to help able to facilitate that, where they have hematologists, other providers. They're talking about how collaboration occurs. What are some of the processes to do to help make sure that your patient is getting better outcomes? What are some of the questions that should be asked between the two parties? And it's been very, very helpful for us in this community that does a lot of work with individuals with bleeding disorders. And so again, Better You Know has not only patient education, but also physician education. And the other one I would recommend if you're really interested in this area is the National Hemophilia Foundation, which is now the National Bleeding Disorder Foundation, has a toolkit for women and girls and individuals with this disorder. And this toolkit gives them things such as how much you're bleeding, questions to ask your provider, things that you need to be aware of, side effects of some of the medication you have, when to call your physician. And I think it's also helpful for us as physicians because it is a tool for us to jump off of when we're discussing things with our patients. Now, I could not be the Dean of Multicultural Affairs without talking about health inequities. And unfortunately, bleeding disorders has had a huge health inequity. Almost 20 years ago, when I went to the National Hemophilia Disorder conferences, there was only about 10% of the lectures were on women and bleeding disorders, 10%. The rest of the lectures were on hemophilia, mainly X-linked disorders. It was very male-driven, the foundation. The research was also driven in that direction as well. But over time, and not because of us physicians, but because of patients, they really advocated for this. I think the main thing is underdiagnosis and misdiagnosis of bleeding disorders. It's underdiagnosed because we don't think about it. And Also, we see hemophilia. The first thing we think of is men. And hemophilia is like what we term as bleeding disorder. So is to get out of that mindset and construct and see that healthcare providers may overlook these symptoms that women have, because all women menstruate. But we need to look at how heavy or the menorrhagia in this group. It's also the lack of awareness of the gender-specific diagnostic criteria for bleeding disorders in women that leads to fewer diagnoses, along with limited access. As I told you, some of those tests that are done are very specific tests that aren't even done by LabCorp. Sometimes they are, but they're in association with one of the centers. And because of that, if someone is uninsured or underinsured, sometimes those lab tests can be very, very costly and can prevent someone from adequately being taken care of. However, communities that work with these centers, if they get those patients in, there's ways that they can get that. That's why I say it's so important for these patients to be seen in the center, can get these tests done for those individuals as well. So it's not a financial burden. The other is research gaps and lack of data. That's getting better, but we need to do more. We need to do more because it's so underdiagnosed. I think we really have more women out there that have bleeding disorders than I really think we are aware of. And I definitely know we have more platelet dysfunction, women with platelet dysfunctions that we are not diagnosing, and more out there that could possibly have a better quality of life and also decrease some of their risk outcomes if they're diagnosed, so that we can give them the correct treatment and also making their lives improved. And the stigma, some individuals, it's still a stigma sometimes of bleeding disorder. What does that mean? That means you can't do this or do that because you have a bleeding disorder. As well as we talked about the financial burdens. So we as physicians, what can we do about it? We can be advocates. We can make sure that our patients get to the right places. We wanted to take care of patients, but we want to also advocate for them and be effective members of the team that take care of them and educate ourselves in ways where we know that we can help them have the best outcomes. Either our adolescent patients, those in reproductive ages going for their contraceptive options, giving them the right options available, those who are starting family building, those even when they're going through their perimenopause and start having hormonal changes and having irregularity in the bleeding, which can be so much devastating for a woman who has a bleeding disorder. So I told you we were going to come back to AC. So I just saw AC actually 3 weeks ago. She's now 38 years old. She's a G3P101. She was diagnosed with von Willebrand's 2. And then also she was very complex. Actually, it's been discussed by the CDC multiple times because she also has a strange platelet dysfunction, which goes back and forth different ways where her platelets don't function and they're also very low. She can go as low as 80 or 90 during pregnancy. Her top high is her platelet function usually goes around 180, 190. But even though she has low platelets, they don't function as well. I've known her, you saw that I knew her when she was 15 years old. I was so proud of her when she graduated from college. I met her boyfriend, her future husband. She brought him in to meet me and I gave approval. I unfortunately missed her wedding, but when she got married, right before, when she got engaged, we had that discussion about, we had it before, but the preconceptual counseling, and she got a referral to MFM and genetics. What was so important regarding that, she had gotten a genetic consult, I guess around when she was around 20, 21. And her members of her family were off to be tested. And we found out her grandmother, her maternal grandmother, her mother, her brother, and 4 of her cousins were positive had von Willebrand's disease. And it was very eye-opening because I take care of her grandmother and her mother. And her mother had a hysterectomy for fibroids and had to be taken back because she had large amount of volume of bleeding 7 hours after her surgical procedure and needed to be transfused over 8 units of blood. And it was very devastating for her, that experience for her, and to now know the real cause of it. That's why it's so important of knowing this. It's really, it affects the family as well. AC had 2 children, which I delivered. They're 9 and 8. Her, both of them were tested, and her daughter, the 9-year-old, does have 1 milligrams. She had 1 miscarriage in between, which she knew about. She decided to use the progesterone contraception, IUD, for contraception after her second child, because she was going, and now I'm very proud to say that she got her PhD in psychology. And why that moved her was because of her understanding that her mental health and understanding how that's not always discussed when people have chronic diseases. She's doing very well, but she's also an advocate. She knows I'm giving this talk, so I'm giving a little bit more. And full disclosure is that the patients, the bleeding disorder women are patients. I applaud them. They really pushed this project. This picture on the side is a woman who had a bleeding disorder. Her abstract art, just seeing, you know, that it's more than her bleeding disorder. She's actually a person with a heart. And when we are looking at these individuals and we're taking care of them, they're more than just a bleeding disorder. And they're complex. They're more than just calling them von Willebrands, because all are not. Just for you to know, AC did not respond to DDE. She was hem-AP, and she has to also get platelets at the time, right after delivery, to maintain her bleeding. So she's a more complex, so they're not the same. So I'm going to leave you on this, that if you're not listening to people who are the most affected, you're not likely to come up with the solutions that will work for them. I think being in this space has allowed me to be a better listener, a better physician. It really, really has caused me to stop and listen, because these women, when you talk in the literature, they'll say the first thing that, why did it take so long for me to be diagnosed? No one listened to me. So I'm charging you as my colleagues to listen. I wanted to take this time to acknowledge Dr. Saidi, Dr. Claire Phillips, Dr. Bachman for all of their support and their mentorship during this journey, and also AC and my bleeding disorder patients. These are my references, and I'd be happy to take any questions.
Thank you, Dr. Ayers. Yes, go ahead, Dr. Bachman.
Well, I wanted to say this was a phenomenal talk, and the first question that comes to my mind, and I know there'll be many other questions, is do other countries globally do the education part better than we do? Do the interviewing in the office setting better than we do? Because from your talk, we have many, many gaps. And the one that I think of immediately is our pediatricians talking to their patients about menstruation, or are these young individuals having to wait until they see an OB-GYN, which may not be until they're in their late teens, early 20s. So is education globally better than ours? And are we educating the pediatricians enough, and the primary care docs too, who see young individuals?
Well, Gloria, you're absolutely right. So Canada does a much better job. We take some of their, because they're more into doing things based on protocols. So when someone has a certain thing, these questions are done. The other group is Australia. A lot of information is coming from Australia as well. Those are the two that come to mind. I'm sure there's others as well, but I mean, you look at the literature, those two come up multiple times when they're talking about surveying patients and getting the information from their histories. And we could all do a better job. And I think our pediatricians, that's another area. I think Lena will share that with you as well when she sees adolescent patients, that a lot of times some of the information that she's giving the mom and the patient is like new information, even though that child has already had the administration for like 1 to 3 years. We know that even with PCOS, I'm gonna take that as an example, the first year of a young woman's menarche, you really shouldn't be saying this abnormal bleeding because there's an adjustment. And that, you know, so when they're sending them to us their first year of menstruation, that's not abnormal. And they're really trying to tell us not to really even diagnose those young girls with PCOS until after 5 to 7 years. So I think there's a lot of education that all of us can do. And I think that's where it comes to having discussions, that the discussions between multidisciplinaries. We do that with our students. We encourage multidisciplinary, but I like just drops off after we get into residency and as attending. So thank you for that question.
And just one other point, do we have the CDC score sheet in our offices so that the individuals can see them, or even parents of young girls?
We should, but we don't. Lena, do you have that? I'm not sure. In Monroe?
No.
I'm not sure.
Because that
But
seems
that's a
like,
very good point.
that seems like a proactive step that we could take and have this available, because it's really important, obviously. Are there any other questions before I have one other question that I wanted to ask? And that is, I know that a lot of bathrooms are now supplying sanitary protection, but should they also be providing education? I mean, should there be something along with the sanitary protection that educates an individual that if they're going through, you know, X number of pads or tampons, that they really should get help?
You know what? That is a really great, because we needed to get out of the box, because education is so important. And I think, Gloria, that is an excellent idea. It's an excellent, because that's where you're going in. And we know that people don't know what normal and not normal, you know, they think there is normal, their idea, because their mom's bleeding is just as much. So that would be an awesome idea to have that pad and how much is normal.
I know Lena has a question, but they do have Narcan now in many bathrooms.
Yes.
Because when I was at a program at Douglas College, I went into the one restroom and there were Narcan there. But I see Lena has her hand up.
Yes.
Yeah,
ma'am.
thank you. Dr. Bachman, just to piggyback off what you were saying about education, you know, a lot of times my adult patients have their daughters and they're always wondering, you know, what age should I bring my daughter to see a gynecologist? And ACOG's recommendation is 13 to 15 to be able to obviously, you know, establish trust with an OB-GYN and to talk about some of these things that we've been talking about to help patients, you know, understand what's normal and what's not. And really to advocate, and, you know, making that first step for an adolescent is so difficult to come to a GYN because everybody associates it with a pelvic exam, and that's like a whole nightmare for them. But I think to, you know, educate our adult patients to say, you know, your daughter probably will not need a pelvic exam, but it is important to come in and so we can discuss some of these things.
That's exactly right, because many patients say, well, my daughter is not sexually active, that I don't have to see an OB-GYN. And that really, we have to change the mindset, as Charletta said. Absolutely. Yes.
All right.
Well, this was excellent. Thank you, Charletta.
Thank you, everybody. Have a great day.
All right. Thank you.